Optic nerve avulsion associated with central retina artery occlusion in a case of penetrating orbitary trauma. We report the case of a 9-year-old male with no significant history. 5 days prior to admission he had penetrating trauma to the upper eyelid of the left eye with a metal rod. On ophthalmological examination, visual acuity in light perception, normochromic conjunctiva, transparent cornea, wide and well-formed anterior chamber, without cells, iris in medium non-reactive mydriasis, transparent lens, fundus with retina with generalized pallor, thin vessels, macula with red cherry spot, and papilla with parapapillary hemorrhage towards superior and inferior, and paramacular subhyaloid hemorrhage. Fluorescein angiography shows delayed filling from the early arterial phase that is maintained throughout the following phases, in addition to the phenomenon of blockage at the parapapillary and paramacular level due to the previously described hemorrhage. In the transpalpebral ocular ultrasound, a hypoechoic image is observed that delimits the optic nerve, as well as a hypoechoic zone in the subtenian space after the exit of the optic nerve from the eyeball with integrity of the scleral surface. Optic nerve avulsion is an atypical form of traumatic optic neuropathy. It is defined as a traumatic detachment of nerve fibers from the margin of the optic disc at the level of the cribriform plate, but without damaging the sheath. The etiology is very varied and ranges from trauma in a traffic accident to penetrating wounds. The diagnosis is clinical, however it can be delayed if there is presence of hyphema, vitreous hemorrhage or retinal hemorrhage. Fluorangiographic findings similar to those found in this case with parapapillary hemorrhage and delayed filling due to arterial occlusion have been reported in other case reports. B-mode ultrasound has been shown to have beta sensitivity compared to magnetic resonance for the diagnosis of optic nerve avulsion imaging. Computed tomography has shown complete or partial avulsion in some cases and no evidence of nerve disruption in others. Clinical interventions for traumatic optic neuropathy include observation-only, corticosteroid therapy, or optic canal decompression. However, it is controversial. In conclusion, there are few case reports of optic nerve avulsion associated with this mechanism of trauma. The history of trauma, the severe post-traumatic loss of visual acuity, and the clinical findings allow us to suspect the etiology. Fluorangiography allows us to assess the integrity of the central retinal circulation, and ultrasound is also useful in the first diagnostic approach.